So this is a 30,000 foot view, and anytime you want me to go down to 5-foot view, just yell. And if I don't know the answer, I will tell you I don't know the answer. If I make something up, call me out on it. And if it's too narrow, if your question is too specific to your situation, I don't deem it to be of general interest, and we can talk about it later. I'll hang around. So for those of you who don't know, greatmed.org is a nonprofit educational platform, and the intention is to have a platform to provide information directly to patients and physicians that doesn't cost anything, that will give evidence-based information to help people have better health outcomes. Today we're going to be talking in general about cancer. If you go to our website, you'll see a lot on diabetes. We have a conference on type 2 diabetes reversal coming up at the end of April. And so the idea is to take this lifestyle medicine information that we would argue is far more important than anything else, any other kind of medical information. And by saying it's more important, I don't mean that other medical modalities aren't important. And we have pulmonologists here, we have gastroenterologists here. I've got to watch out that I don't get beaten up in the alley on the way home. But for example, colonoscopies, vital. Bronchoscopies, terrific when you need them. But more importantly, and if people weren't sick, we wouldn't need anesthesiologists at all. So the idea is to say, how do we keep people from needing to have these interventions for the most part? Colonoscopies are an exception, I'll hand you that. So that's the mission of greatmed.org, and for the people in the audience that are helping us keep greatmed.org, which is fully philanthropically supported, thank you. So let's for a second just dwell on what lifestyle medicine information do you believe? So you can get lifestyle medicine information that says you should be gluten-free or dairy-free or keto or paleo or vegan or whatever. And so the question is, how do you decide who's telling the truth and who's not? First of all, if it's me, obviously. But how do you tell if I'm on track or if I'm just not exploring an idea I've got that I've taken myself too seriously about? And the idea is to first of all realize that lifestyle medicine information is inherently poor quality. And that's the vagaries of human nature, of gathering data, of the type of data that we're gathering. It's really not good data for the most part. And so therefore our rule is to have at least 3 lines of evidence behind any recommendation we make. If there's not 3 lines of evidence, we think it's probably not worth pursuing, and there's a few exceptions to that, but very, very few. And the type of thing that is lines of evidence is well-established historical precedent, and I like, if people have been eating tomatoes for hundreds of years, they're probably okay. And that's a little sloppy, but I think it's been well proven. We argue that a Greek grandmother is a better source of medical information regarding nutrition than a Harvard professor of nutrition. And I've got good data to support that statement if anybody thinks that was sloppy. We have things like randomized controlled trials and meta-analysis and systematic reviews. We have observational studies. We'll be using some stuff, for example, from Nurses' Health Study and the Health Professionals Follow-Up Study. But none of these should be used by themselves. Documented case series, if somebody tells you, hey, we've got 5 cases of X that did this, and these were the outcomes, and they're well-established cases that you can actually defend and see that the biopsies were there, that the history is clean, then we would include that too. But they've got to be pretty well documented. We're not going to go with just plain anecdote, because lives are on the line. It's lives, money, time. Patients are short of all 3 of those. And so our job is to try to be as responsible as we can be with respect to providing good information. When you're looking at data, find out what the actual claimed benefit is. So something, for example, that reduces a tumor size but doesn't change the patient's overall clinical course. Something that creates an antibody response in the blood, but doesn't change the actual clinical course of the patient, is probably not something that's terribly important to you. We need to have things, for example, and you'll see that we emphasize mortality reduction in the studies that we cite. And is there opposing evidence? If you don't know both sides of an issue, you don't know what you're talking about. And I can't tell you how many salesmen I talk to. They don't intend to be salesmen. They're just people who are infused with an idea. They actually don't have anything to sell except their idea. But they've read one headline, and that makes them an expert. And so watch out that you're not listening to people who've just read one headline. Say, hey, is there anything that opposes that? And before you take anything too seriously. And instantly, you can interrupt me anytime. If I say something if I say anything that doesn't seem to be, that you've got questions about. If you've got a question.
You might be talking a little too fast.
Me?
Yeah, maybe.
That's my sister Mia, and she is suggesting that sometimes I talk too fast. I just don't know where she comes up with these ideas, but I will slow down. And so interrupt me anytime. If you've got a question, then probably somebody else has the question, or if I'm talking too fast. So we're going to be talking about interventions such as food, physical activity, and waste management, and looking at some details within all those things and trying not to bore you too much. This is an overview slide that we use quite a bit that sort of just reminds people of the potency of, so people who've heard my lectures before, they've seen this slide before probably, because it sort of looks at the potency of lifestyle interventions. And so this is from the Nurses' Health Study and the Health Professionals Follow-Up Study, so 130,000 people followed for 20 or 30 years. It's a Harvard study. Your tax dollars at work, and we will probably never see a study of this type again. It's nobody dares stop the funding for it, so it keeps going. But it's so expensive, it's unlikely that anybody's going to do something like this again. But it identifies this group that have good diet quality, a good omnivorous diet. They say they're low in red meat, and actually in the study they actually average about 3 ounces a day, so pound and a half a week of red meat. Body mass index, these people are not too chubby. So they have a waistline that goes in, not out. 30 minutes or more of moderate to vigorous physical activity, moderate alcohol, and we can talk more about alcohol later if you want. They don't smoke. And these people live longer, significantly less all-cause mortality, less cardiovascular death, less cancer mortality, 65% less, 90% less type 2 diabetes. These factors that we're seeing here are things that anybody can do. There's nobody on the planet that can't do these things. Well, as long as they have access to food, I'll give you that. And these are interventions that would actually change our entire society if people did them. And yet, how many people do 30 minutes or more of moderate to vigorous activity, even though they can? And so we plead with people to pay attention to this basic data and realizing this kind of data is more important than anything a doctor can do for you. It's not that doctors aren't useful. I mean, I need to earn a living, okay? But what we can do for you is not as great as what you can do for yourself. So that was a general omnivorous, they call it the American Healthy Eating Index type diet. And if we alter the perspective a little bit and talk about the Mediterranean diet in particular, then this is an analysis of 2 million people followed for about 20 years, and they have this scale that they use to determine adherence to a Mediterranean diet based on a questionnaire. And so this is an example, of course, like all these studies, where when you've got a bunch of people filling out questionnaires, you need to remember that there's a lot of sloppiness. So this is a reason to only follow data that has multiple similar studies all showing a similar result. But for every 2 points on a 10-point scale, there is a 6 to 12% less cancer or cancer death. And we see this, and plus a broad range of other health benefits. And we see this with Mediterranean diets pretty regularly. In this Mediterranean diet study, so it was actually a heart disease study, where they randomized people, so unlike the last two studies I just mentioned, which were observational. In other words, they took a whole group of people, said, hey, what do you do? And then they go back every year or two and say, what do you do? And then they plot these people and look at their health outcomes. in the last year or two since we talked to you last? What diseases have you got? That kind of stuff. And they hope people are being honest. Unlike those, this is a 4-year randomized control trial where they compared people with a Mediterranean diet compared to what they called a healthy Western diet. So it was actually 2 fairly good diets compared to each other. And the Mediterranean diet group at the end of 4 years had 60% reduction in all cancers and mortality cut by about half. We see numerous other studies that look at this, and from the observational perspective, I could just have a couple of them here. These have 2 or 3 million people enrolled in them. And this is another thing to be cautious about, because if you've got 2 or 3 million people in a study, you've got to make sure to think about whether the data actually apply to you, because you might be a lot different than a lot of those people there. So be cynical at every step of the way. In these studies, they found that fruits, vegetables, whole grains, and fish were the most important diet variables. And somebody earlier, just before the talk, asked about grains and mental health. And I make the case that whole grains, of all the food groups out there, I think whole grains, you could argue, are the single most important group for good health outcomes. And so the people that are saying you shouldn't eat grains, I think are not certifiable, because we don't have a psychiatrist on their case. But Lou, are you going to harass?
You said be wary of some of these research studies. Of course, I haven't looked at them like you looked at them. But I look around the room, and frankly, with a few exceptions, we're a bunch of boomers. We are not all the other population. So we're all in our late 60s, 70s, or thereabouts.
Those of you who aren't, or don't look like you are, then just ignore him. He doesn't mean to be offensive. It just
that applies to us over our next 10 or 20 years of life, because we aren't going to live 30 or 40 years.
So we do have data out to about 80 years old from Nurse Health Study, for example, which is in my longevity talk, and supports the same idea. So. So in the 50 to 80 age group, in these epidemiologic studies, when they've looked at that subgroup, they get the same data. Okay. And in practice, so I'm a general internist, and so I'm taking care of people who are, like half of my patients over 75 years old, 2/3 of them are over 65. So I'm very familiar with old codgers, Lou.
Well, to some of us, 65 is young.
True. And well, 65 is young to me, don't forget. And when we look at this in practice, then we think that we see this. So when I was talking about the bad quality of data, if we saw in practice examples that showed that this data was wrong, obviously we should pay attention to that. In actual fact, when we see our 80-year-olds that are exercising for 30 minutes a day, eating well, and not too chubby, not smoking and not drinking too much alcohol. Of course, the smokers generally don't reach that time anyway, except in a nursing home. And then we don't. Then we see the same vigorous people. In December, I saw a 98-year-old. I was doing a house call on a 98-year-old surgeon who looks after his wife. That's why I do the house calls, because she's pretty ailing. He can come into my office, and he's standing there, and as I'm leaving, and he said, "Yeah, well, I'm 98 years old. We should be preparing for my 100th birthday." And that's how he felt as he ran up and down the stairs seeing me out. I've got a guy he's about 86 when this happened. So he first got involved with us when he was about 80, and I said, "You've got diabetes and need to lose weight and start getting some exercise and eat better." He said, "Well, I came here about my hip replacement." I said, "Well, if you do all those things, maybe you don't need the hip replacement. Put off your appointment a little while and just see how you do." So he took better care of himself, didn't get the hip replacement until he was 87 or 88. But when he was about 85 or 86, he came in and he had a couple of broken ribs. I said, "Wow, what happened?" And he said, "Well, I was stepping off the treadmill and I tripped on a barbell." And I said, "That gives you some kind of a word. I don't know what it is." And he was 86 or 85, something like that at the time. And we see this. So and he didn't get started until he was 80. A recent study where they looked at people 85 versus 65 and weightlifting. And so these two groups started weightlifting, and the 85-year-olds gained muscle mass at to the same degree the 65-year-olds did. So all this stuff that you hear about sarcopenia and you can't overcome it, you can at least partly overcome it. So I digressed. Did I answer your question, Lou, or did I just, okay.
Very well, thank you.
Okay, so this slide refers to cancer prevention, and I've only given you a couple of studies here, but we have buckets of studies on the Mediterranean diet and prevention, both from randomized controlled trials and observational studies. If you look at survivorship, it gets a little more cloudy for cancer overall. So survivorship refers to if you've got cancer and you go on the Mediterranean diet, are you more likely to survive? And that data is promising. It trends, and this is a nice review of the subject from last year. And it trends towards positive, but it's pretty poor quality data overall. But for the Mediterranean diet data, once again, buckets of studies, and we're looking at buckets is a technical term I'm hoping you're okay with. So what this shows for the breast cancer, which has been much better studied, and probably because it's a study of younger people, younger women who have a lot more life, and there's a lot more invested in these studies. And so you have consistent data showing 20 to 30, possibly as much as 34% lower mortality. And remember, we're talking mortality here. We're not talking about shrinking a tumor or something like that. We're talking about overall survival. And we can also show evidence from other studies that show a dose-related relationship. In other words, the greater the adherence to the Mediterranean diet. And the way they do that is there's these scores that different people have established. And so people do their surveys, and depending on what they answer in the score, they get in the survey, they get a score of 16 or 18 points as to how adherent to the Mediterranean diet they are. And the higher the score, the greater the survival. And this data, I would submit, are there any oncologists in the audience? Guess not. This data compares extremely favorably with what we see with chemotherapy and radiation. So it shouldn't be diminished because so much of what we do, for example, in chemotherapy, provides improved disease-free survival or shrinking tumors, something like that. Much of it does not improve overall survival. So what we're seeing with lifestyle is it improves, and this is just diet. We haven't even talked about exercise. What we see with diet is it improves overall survival. And that's a key finding if you're ever comparing anything to anything is, am I going to be alive? Any questions about this at this point? Apart from Lou. Okay.
Just kind of a brief sidebar, but why is it that if you ask your general oncologist,
Thank you.
I mean, I've asked my husband has glioblastoma, and just in speaking with his oncologist, I've done some of my deep dives into this nutrition element, but he just kind of did the classic, just eat whatever makes you happy, just try to get some calories in.
Ice cream is better than nothing, yeah.
Which is fine, because you don't want to lose too much weight. I understand that element of it. But I mean, based on all the conversations I've had with similar, and I'm sure lots of us could share the same story, where it seems like in general it's just the evidence relating to diet is so pushed under the rug that it's almost just alarming, and which is why we're here, obviously. But have you had any, do you know why that is generally the case with your standard oncologist?
I think I do. First of all, everybody is stressed in terms of what they can accomplish in an office visit. Lifestyle is really complicated, and that's, if a little sales pitch here, that's why Great Med is being put into action, so that the oncologist can just point people to Great Med. They already know that it's reliable information, not a bunch of flaky stuff trying to sell vitamins or some weird alternative therapy, but just giving people the data that we have. And that way it doesn't take the time out of the office visit. That's number one. Number two is it's not the way we're trained to think. In fact, for many doctors, I think a lot of doctors think I'm kind of nuts. I think a lot of doctors think I'm kind of out there, maybe a quack. Nancy just put it out, yeah. And so the whole diet as treatment is as part of a treatment is, I think, just not part of our culture. So there's a big cultural problem. Thirdly, the marketing. There's lots and lots and lots and lots of reasons for us to hear about drugs. There's conferences that are paid for by drug companies. There's articles in journals that are paid for by drug companies. There's drug reps, so we don't see them as often as we used to because they used to bring us lunch and nice gifts and things, but we don't get that anymore. So there's all those marketing forces and where the money flows. There's just no money in this. It's not sexy. All it does is save lives as I see it. So I think it's a big cultural problem, ultimately. The physicians in the audience, how would you answer that? Would you agree with my answer, or Colleen?
I think oncologists are trying to get their patients through chemo, and that's the goal. And you do need calories. Would you repeat what you said?
So Colleen's an internist, and so she said, oncologists are busy, tell me if I got this right, just getting people through their chemo and radiation and all those issues. And would I be correct in saying that they just don't have time to take this on?
They don't have time, and they encourage calories, yet you have to get something in.
And I argue that's actually an erroneous, Harry.
Well, if someone's got a disease process that reduces their appetite or makes them lose weight for other reasons, you want calories so they don't lose weight. So that's part of it. And just because high-calorie food, as we all know, is often tasty and easy to eat. People may eat ice cream when they really don't want to eat broccoli when they're sick.
Huh, who knew?
You want to sum up what you said?
Dr. Bray was saying that people would prefer ice cream over broccoli, and I just find that so amazing. You lie. Did I answer your question? Oh, sorry.
I was just, I'm a nurse in cardiac and pulmonary rehab, and I guess this is not a cancer perspective, but I think that you're right, it's a cultural thing. Patients have to reframe their thinking because they're used to, oh, I have something, I need a pill. I have high blood pressure, I'll take a pill. My cholesterol's high, I'll take a statin. So it's work and discipline to make changes in the way you eat. So, and it can be done because we talk about that in cardiac rehab. We talk about the risk factors for heart disease. We talk about the benefits of exercise and how it helps with your weight, your blood pressure, your blood sugar, and so, cholesterol. So it's, we talk about food first as well, but it is a reframing that needs to happen.
And would I be, by reframing, could I include emphasis?
Yes.
It's simply...
Well, yeah. I mean, we can emphasize it in cardiac rehab, but we're not the provider.
Yeah. So another aspect is that, and this is once again softer data, but we are pretty sure that we see this, and I'm going to give you one study that seems to suggest as well. We know from in surgery that people who take better care of themselves heal faster. I don't think there's any doubt about that. I haven't put up any of the surgical literature on this, but it appears that people get fewer chemotherapy and radiation side effects too. And that's really important if it's true, because it means that you don't need to get dose reductions, which in turn, if you're doing dose reductions for a patient with cancer therapy, your chances of having a successful treatment are reduced as well. And so the idea that the lifestyle measures appear to reduce side effects from conventional therapies, I think is an important side benefit as well. This was a really interesting study where they had 111 patients with colon cancer and stage 3 colon, the multiple stage colon cancer, and it's only 111 patients, but they're randomized to 3 groups, stratified by stage. And one group were told to eat better, basically, normal foods, but eat better foods. Second group were told to just eat whatever they did and have a high protein supplement, which basically usually means an industrial food, some kind of one of those powders. And then third, to have a usual diet. And the nutritional education group had lower total mortality, less treatment-associated toxicity, and better long-term quality of life. So it's a win-win-win. And this is a Kaplan-Meier curve, which can be sometimes exaggerating. But you can see this is the group that were told to eat better food. This is the group that were told to take a nutritional supplement. And this is the group that weren't told to do anything at all. And these differences are significant. So it's it implies that there is a benefit to this. Now, there aren't too many studies that have looked at this, but it certainly looks very positive, and it fits with what we see in our patients. We had a breast cancer patient, and I was presenting her case at a conference, and one of the oncologists at the conference said, "Miles, that's not a case, that's a miracle." And I'm still not too sure if he believed me or not. But the patient did so well in terms of going through conventional therapy with excellent outcomes and virtually no side effects. But she was exercising, she was eating beautifully, she was putting everything into it. And that's and of course another aspect to this whole lifestyle information is those are different kinds of people. Those people do better. And so for you want to say, hey, do I want to make myself one of these groups of high-powered people who really make good decisions and do well, or don't I? Because most of the work is between your ears. I'm just going to make a sales pitch for extra virgin olive oil because there's so much discussion about oils, but it's the only oil that we see that has association with lower cancer incidence in multiple studies, lower total mortality, huge range of benefits, including mental health. And we don't have any other oil that fits this, that has this kinds of findings. And I just keep seeing all these discussions about avocado oil and canola oil and everything, and people seem to be missing the point. The point is, does this oil help keep you alive? And olive oil is one of the only individual foods that you can say this about. It's really kind of a unique product. And it's actually not a vegetable oil, it's actually a fruit juice, in case you're wondering, in case you care about that. It's kind of a fun thought. But there's all this discussion about seed oils, which may well be true, and the evidence for seed oils isn't strong. But we shouldn't be talking about seed oils. We should talk about things that have good health outcomes, such as extra virgin olive oil. And this is just there will be a pop quiz on the third study. But this is just shows you the kind of range of studies that we have in lifestyle medicine. This is called a forest plot. So if the center of your little line here is on this side, it means that olive oil is better for you, and if it's on this side, it means it's worse for you. And so this is an example where you actually can find it. So if I was to cite these two studies, I'd say, there's a trend towards harm with olive oil, but it's actually non-significant. But there is no significant study that shows harm with olive oil, and a very consistent finding. And this is the kind of thing you want in any kind of research, is you want to see a consistent outcome, not a scatter. Vegetables and whole fruit really figure highly in the lifestyle medicine research. There's this number around 600 grams a day, which is about a pound and a quarter, that keeps coming up where they've tried to quantify intake. But somewhere around that region, and so the way we suggest doing it is have fruits or vegetables every meal and snack. Build your whole diet around fruits and vegetables and protein. And that has pretty good consistent evidence with better health outcomes. Heart disease, diabetes, mental health, weight management, you name it, not just cancer. Whole grains and beans and legumes, I mentioned whole grains earlier. And part of the issue, of course, is that whole grains in human nutrition figure more strongly than beans and legumes anyway. But both of them are associated with less cancer risk in observational studies. I mentioned modern wheat here because a lot of people say, well, you have to eat wheat that's grown from grains that were around 300 years ago. And that doesn't seem to be the case. GMO wheat just seems to save your life just the way other wheats do. And we would argue that the only people who need to avoid gluten are the people who are gluten intolerant. Sort of like the only people who need to avoid strawberries are the people who are strawberry intolerant. But we don't think there's any general condemnation of gluten. Any questions about that point? Sometimes that's a yes.
I do, just to clarify that. So, yeah, you hear a lot about the grains these days aren't like the grains our grandmothers ate, so you're comparing different things. So I sometimes wonder about that. But am I hearing you say the grains today are just as?
Well, we actually don't have any data on grandmother's grains. That's the issue. So that's an argument of silence. But these studies are all done on modern grains.
And so that's good.
Yeah. So maybe your grandmother's grains were better. You never know. Yeah, but I'm not about to plot an acre of wheat behind my yard. So the issue here is that really the intact whole grains. So if you really want high-powered grains, you want to cook them yourself. We're pretty hardcore. We even we grind our own flour. Anybody else here grind their own flour? Aha, we got a grind flour grinder. Yeah, so there are a couple of lunatic fringe people here. But it really, it's kind of a fun thing, and it makes you feel really self-righteous. Yeah, because you have to bring it up and talk to people. Like when I'm at a party, I ask people if they grind their own flour. Not really. So I'm going to summarize what Miles Hassell's version of Mediterranean diet is. And the reason it's Miles Hassell's version is that there's different scores, and they're all slightly different. And so recognizing that there's variations in the theme is not a bad idea. So lots of fruits and vegetables, beans and legumes, raw nuts and seeds, whole grains, good fat. And the thing about good fat is it settles down your appetite. So it has a higher satiety factor. Good fats from whole foods have a ton of nutrients that aren't present anywhere else. They give you good mouthfeel. If we could get people to stop buying breakfast bars or protein bars and instead have a handful of almonds and an apple or banana, I think they would save money and they would be healthier. And then extra virgin olive oil. We think that animal protein tends to get dissed, but people who eat a wide range of animal protein seem to do a lot better. Cultured dairy, we'll have a slide on the microbiome, and if Dr. Bray lets me. But we suggest people have cultured dairy. I'll mention later on, I'll mention about fresh sauerkraut, all these different things that provide the natural bugs to your gut. Moderate alcohol, we'll talk more about that. And we argue that the cancer patient, or all patients, they should worry about the whole food component of their diet. I would argue they shouldn't worry about saturated fat or cholesterol in their diet or total fat. The Mediterranean diets that we have good data for range from like 28 to 40% calories as fat. And some of the studies even go out to 60%, but they're not as good studies.
You talk about raw nuts. Are toasted, just in the oven toasted, they taste a lot better? Do you lose the
If you toast them, we're okay with that. In our book, we gives directions, yeah.
Okay.
But if you're eating toasted nuts from a supermarket or something that were toasted who knows how many months ago, and you're taking this high-fat, easily oxidized group of chemicals and then inviting them to be oxidized, that's just not a good idea, as far as we can tell. I don't have any data for that statement, however. The other reason not to use the commercially done ones is you eat too much of them, and then you get chubby. Leslie? Well, actually, Anna gets up very early in the morning, and and she has 2 stones, and she's just. It takes her 3 or 4 hours, but it's she has the time. No, there's something. We sorry, I digressed. There's something called a mock mill is the one we use. There's numerous mills out there. We use a mock mill. It's a German stone mill, M-O-C-K. I think the guy's name is Frederick Mock or something. Anyway, he's a German guy. And but there's many good mills out there. We've been through 3 or 4, I think, and the mock mill is by far the best.
One question about yogurt. You say unsweetened yogurt or kefir. So many of the yogurts in the grocery store, the racks are sweetened, or they're a fruit flavor, and that's what's bad with them, and we should
just flavor them yourself. So we would argue that almost any food you should get in its most primitive form and flavor it yourself.
Nancy's is local?
Nancy's is good, yeah. Brown Cow, Stonyfield, There's a lot of good yogurts out there, but get them plain, and flavor them yourself. Blueberries, maybe a little touch of honey, maple syrup, and even when you add your own sweetening, you're not going to add as much sweetening as the commercial people add. Let's see. I guess we've gone through that slide, haven't we? The microbiome. Harry, do you feel like talking about the gut microbiome?
That's a 3-day talk.
So, given that you probably don't want to listen to his 3-day talk, I'll give my summary and then we'll see if he agrees. This is actually Dr. Bray's area. So we would argue the healthy gut microbiome is associated with a reduction in almost all health problems. Is that exaggerating, Harry?
Probably.
Oh. But mental health, cancer, obesity, diabetes, heart disease, infections, I would submit. And we'll just stop listening to Dr. Bray. And the things that seem to be related to a healthy microbiome: whole food fibers, whole food fats, probiotic foods, vinegar and wine. And you can actually argue that all whole foods are actually, because they're all kind of dirty, might be as important a source of the microbiological ferment as anything else. Exercise actually improves the microbiome and minimizing antibiotics and refined sugars. Anything you'd add, Harry? Anything you'd delete?
One of the things I think is interesting is refrigeration and how that reduces natural fermentation. Everything is in the fridge. Cheeses are in the fridge, whereas we never used to do that. I think it was only in the last 40 or 50 years that we've insisted on keeping everything cold. I think if you take some cheese out, you're going to eat it, leave it out for an hour or two, but it's much tastier if it's warmer. And then the natural microbes in the air will help ferment it.
Find a home?
I think that's much healthier than taking probiotics.
Oh, yeah. The implication here is don't take probiotics. Probiotic pills narrow the spectrum, I would submit, and probably are not as good as what Dr. Bray is talking about. Any questions about the microbiome? It might be actually much more critical than we realize.
Are you saying that just leaving it out for a while helps?
Yeah, I think so.
Like sourdough.
Yeah.
Warm it up.
It's like with bread starters, leave them out and they get tastier.
Which is how many people make sourdough. It's the same kind of concept.
Monica,
John.
in that last slide, you skipped over the important subject of alcohol.
Oh, because I've got a couple of slides on that.
What is moderate alcohol?
Well, I've got a couple of slides on that. Yeah. That's it wasn't, and a friend provided a resource for me. Something else I think is underrated is the importance of avoiding commercially processed foods. We now have multiple studies over the last 15 years that consistently show that commercially processed foods, what's in their literature is called ultra-processed, it involves most foods manufactured outside the home, including breads, protein powders, protein bars, all these things that are made to look like they're really good, but it appears that the temperatures and pressures that are involved in making a food shelf stable. For example, if you took the ingredients in a Luna bar and chopped them all up and stuffed them in a piece of Tupperware and stuck it in your cupboard, it would look quite a bit different in a few days or a few weeks than a Luna bar does, because it'll be fuzzy and possibly greenish, which is really good for probiotics. I mean, that's actually really good for your gut, probably. That's what Dr. Bray was talking about. But the Luna bars don't do that, and so there's aspects of these heat and temperature, high heat and high pressure manufacturing systems that seem to create this thing that the guys that do this research call neonutrients. In other words, they change the chemicals in our food. But exactly what the mechanism is perhaps less important than the very consistent finding that these foods, which are almost 2/3 of the American diet, are associated with a broad range of adverse health outcomes, including cancer. And it's demonstrable in multiple countries, multiple studies, and it's demonstrable as a dose relationship. In other words, the more of these foods you eat, the more adverse findings you get. And that's important because when you see a dose-response curve in medicine, it raises the probability that the relationship is correct. So we would argue it really means you probably need to make most of your own food. And we don't think there's an easy way around that equation, and it's not something people necessarily want to hear. I don't think there's a way around it, unless you have a private chef, which is making your own food, I guess. But you see a significantly increased total mortality, cancer, especially breast cancer. And we see a lot of it's associated with these sweeteners, and especially sugar sweeteners. But the data is much poorer for those than the ultra-processed food in general. Any questions about ultra-processed foods? How am I doing time-wise, Shelley? Okay. I can talk forever, so I need a handler. The sugars and carbs, so people say that cancer feeds on sugar, and I don't know if that's correct, but we do know that it appears that people who eat more sugar don't do as well. And there's a couple of possibilities. One is the direct metabolic effect of sugar and its effect on insulin and other fat stores, inflammation. There's a bunch of different mechanisms by which sugar might do harm by itself. There's also the dilutional effect. If you're eating more sugar and white flour and white rice, you're going to be getting less calories from other foods that actually have nutrients associated with them. This concept of empty calories might be an important factor. And so there's this complex relationship between being too heavy, dietary sugars and refined carbohydrates, being too lazy, sedentary, and insulin resistance. And these factors all interplay, and I think it's really hard to tease them all out. We do seem to see a relationship between especially sweetened drinks and cancer and heart disease. I don't know, does anybody else remember, I think it was in the early 2000s when the Coke cans had the healthy heart symbol on it? It didn't last for more than a few months because I think there was such an outcry. But somebody wrote a big enough check that the American Heart Association was willing to put their stamp of approval on Coke. I thought that was pretty funny. But it tells you how money-driven the medical profession are, because it made no sense, which is why it didn't hang around. And we do know that higher blood glucose and insulin levels seem to be associated with higher cancer mortality, and we see that from diabetes research. Type 2 diabetes research. I don't think we see that with type 1 diabetes. And we see it also in pre-diabetic patients. So these are people who have higher insulin levels, higher glucose levels, but they're not high enough to be truly diabetic by our conventional criteria. And that may be partly due to the whole the growth hormone aspect of insulin. So it's a really interesting area. But this is sort of an idea of how to sort of think about it, that this inactivity and insulin resistance and central obesity and dietary sugars and starches all feed into all kinds of disease processes. And I could put dementia, which is sometimes called type 3 diabetes. I could put depression in that mix. But exactly how all these factors interplay is really unclear. What we do seem to see this relationship between all of them. And we see a strong relationship between cancer incidence and mortality and being obese. So the idea of and this is a slide that looks at, and this right-hand one is looking at death associated with breast cancer itself and death related to other causes, and showing that the greater the level of body weight based on BMI, which is a suboptimal measure of body weight, but it's the one that's easiest for us to gather. Whether it's non-breast cancer related death or breast cancer related death in these patients, then being heavy made their outcomes worse. And so here's my, you can spend $1,000 a month on Ozempic or whatever it costs these days, or you can do these things. How's that? And so this is your entirely free summary of what we think works for weight loss every time. Now, whenever you see a doctor saying something works every time, you know that they're probably not telling the truth. But this gets pretty close, I think. So avoid sweets, white rice, and foods made of flour. Start every meal and snack with a whole fruit or vegetable. imagine that before you ate anything else, every time you ate in a good day, you had like an apple or a banana or a couple of stalks of celery or whatever. You'd eat less. Protein with almost every meal and snack. Protein and fat shut your appetite down better than anything else. Prepare almost all of your own food and bring your own lunch to work. Think twice about your portion size. Can you stop now? Do you need that dessert? And so on. Work on a healthy microbiome, because the healthy microbiome seems to be associated with less obesity, and less obesity seems to be associated with a healthier microbiome. Brief exercise, enough to be short of breath, at least 1 minute 3 times a day. Now, if people want to do more, that's great. But I'm not sure we've ever seen a person doing a minute 3 times a day and these other things enough to be short of breath each time who hasn't done really, really well. And don't look for excuses. There's a solution for weight loss for everybody, but if we're looking for excuses, we're not going to be successful. Nutritional supplements. So I would argue that the nutritional supplement industry is a less ethical arm of the pharmaceutical industry. And so we should, in my opinion, treat nutritional supplements with the same cynicism that we should treat all pharmaceuticals. And the sort of way to approach it, it's because just like with all pharmaceuticals, there's some that are really valuable. If I've got shaking rigors and a bacterial pneumonia, I would hope that somebody would provide me with a pharmaceutical, for example. But overall, if you look at the last 30 or 40 years of nutritional research, nutritional supplement research, which isn't all that extensive, but it is out there in randomized controlled trials, we have not seen much evidence for benefit, except in very few cases, and we have seen evidence of harm. So the part of the problem is that nutritional supplements don't deliver nutrients that are in the same form as is in food. Chemically, they're quite different in most cases. And so, although some of them can be better than nothing, if you've got a B12 deficiency, taking a synthetic B12 is not a bad idea. Then in general, go for food whenever you can. So we only use supplements for very, very specific reasons. For example, with chemotherapy-associated diarrhea, we often get really good results with glutamine. But that's a very specific application using it as a chemical. And so whenever anybody tells you to use a supplement, ask them what the data are. Look at the probability of an outcome that helps. For example, if I say, hey, you've got osteoarthritis of your knee, try 3 months of glucosamine. If it hasn't worked, stop it. We see people coming in for year after year after year, and they've been spending like hundreds of dollars a month sometimes on their supplements. And I say, hey, have these helped you at all? And they say, well, I don't know. I'm thinking, this is nuts, because these are chemicals. These aren't natural. Vitamin C for cancer is a really interesting one, because if you incubate cancer cells in 15 millimolar vitamin C, you can kill most of those cancer cells. Getting that to work in humans, we haven't been able to do it. And so because somebody shows you a mouse study or a theoretical study or a bench study that looks promising, doesn't mean it's actually going to work in you. And so what you have to do is ask for research that actually relates to real humans, like you. Alcohol. Somebody wanted me to get to alcohol. So in general, I am not aware of a single large epidemiologic study in which alcohol has been a component of the study to see if you drink alcohol or don't drink alcohol, how do you do, in which alcohol as an independent variable has not been shown to improve health outcomes, including measured by total mortality. I'm not aware of a single exception to that. And so that's the first thing, is this is really consistent data in observational studies. However, we don't have any randomized controlled trials. It's really difficult to do randomized controlled trials in this area of any length, because people either drink or they don't drink. If I asked people who drink to not drink or drink for the next 4 or 5 years, then they probably wouldn't enroll in my study. It's typically part of the diet and Mediterranean diet studies, which are the most robust group of diet studies. However, the data are really confusing when we start bringing in other analytic methods. So the Surgeon General report last year that said, hey, you shouldn't drink any amount of alcohol. First of all, it ignored, I would submit, the overall mortality reduction in people who drink out more moderate amounts of alcohol, because it is true that alcohol has either a neutral or a slightly adverse effect, even at moderate levels, for cancer. But the benefit for cardiovascular disease is so great that it swamps any potential harm from cancer. And I'll show you some data on that in a second. So one of the really interesting, this is the type of an analysis that looks at the low levels of alcohol consumption. By that I mean up to about 7 in drinks per week. That probably shows that it doesn't increase cancer risk and does reduce your risk of dying. That should be of some benefit and of some note. And that the lower risk of mortality is primarily appears through the cardiovascular benefits, which are partly through the diabetic benefits. Especially in women, drinking alcohol reduces the risk of type 2 diabetes significantly. So then, this is an older study that tried to figure this out and showed tiny increases. So in the epidemiologic terms, these are really a 3% increase is very, very tiny. And that's for small amounts of alcohol. Medium amount, this is like 1 to 2 drinks a day, and this is greater than 2 drinks a day. And so, 1 to 1.5 drinks a day, and then over 1.5 drinks a day. And you see, especially for women, when you start getting up 1.5, 2 drinks a day or more, you start seeing much more cancer, especially breast cancer. So there is a reason to be concerned, but probably not at the low levels. And this was I'm not aware of any other studies of this nature, but this was done by Pam Goodwin and in Toronto, I think. It was done by, anyway. So it's done by a big Toronto breast cancer group. And they had women with invasive breast cancer, so these were not DCIS patients, followed for 11 years, and found that those who drank a little bit before diagnosis had actually improved breast cancer survival. Those that kept drinking after diagnosis had lower all-cause mortality. And that was primarily because of the reduction in cardiovascular risk for that group. And they did not have any increase in breast cancer-related mortality. And so I just can't find any data that says that there's a significant harm for breast cancer patients in drinking alcohol. This is Wendy and Mark Winifred's comment. Based on the best available evidence, it appears that modest alcohol consumption after breast cancer diagnosis, up to approximately 1 drink per day on average, may be associated with optimal overall survival without compromising breast cancer-specific survival. So this is the kind of data that needs to be discussed, and we often find that people who have an opinion on this don't know that there's actually an opposing view. And that's your job as a consumer, is that sort of know what different sides say. And if you find out that I'm wrong, send me an email or something. Physical activity. So higher levels of fitness are associated with less cancer, less cardiovascular disease, higher quality of life, everything's better. And you live longer. And the data for cancer is, in terms of prevention, are pretty striking. I mean, big reductions in multiple studies. And so we really think that as a medical community in particular, as a sensible community, as a who cares about people community, we really should be pushing for the 30 minutes or more a day of activity, vigorous physical activity. And I think it would just transform our society, I think, if we could. And the data are not borderline. They're not debatable, in my opinion.
Does it make a big difference whether you just bang it out first in the morning to get it done and out of the way, a good 30-minute to hour workout, versus spreading it out over the day?
It's a definite maybe.
Okay.
So the only study I'm aware of that looked at this was in type 2 diabetics, and they took people who had a brisk walk 45 minutes a day, or they split it into 15-minute walks 3 times a day. And the 3 times a day people did better, even though the volume of exercise appeared to be the same. And the theory around that, and it's the only study that I'm aware of that looks at this question. And the theory is that you increase your metabolic rate, and the metabolic rate stays high for quite a while. The reason we push for 3 times a day exercise is partly based on that study, but partly based on the fact that if I tell people to exercise 1 minute 3 times a day, doing something vigorous, they don't have any excuse. There's absolutely no way you can wiggle out of that unless you just don't want to do it. And so we would argue that getting people to exercise 3 times a day is not a bad, and it's really not hard once you get into the habit. Doing something before you go to work, if you go to work, for the people who aren't old codgers here, doing something in the middle of the day, doing something at the end of the day, and don't demand too much of yourself. Just do it, because if you can do 1 minute of something vigorous 3 times a day, and the thing is, I like to demonstrate this in front of the audience, but it always makes me look slightly ridiculous. I used to have a skip rope that I'd do on stage. A minute of skip roping. How many of you can do a minute of skip roping? Now, imagine that you're somebody who started skip roping when you're, say, 60 or 70, and you skipped 5 skips a day. 1, 2, 3, 4, 5. And you kept doing that every day until you're, say, 90. Think of what it's going to do for your lower muscle mass, your balance, your attitude. You're going to be a different 90-year-old. And what did that take you, 5, 7 seconds? And so that's the way we think people should think. Because I can't tell you how many people in their 70s and 80s, I ask them to do this, and they can't get off the ground. And these are normal-looking people that are moving around just like anybody else would, but they have let themselves get so frail that they can't even do that. So what happens when they walk across the room and slip and can't catch themselves and fall down and break their hip and die? It really is a quality of life issue. It's a cultural issue. It's yeah. Should I go on longer on that one? Yes. Oh.
In terms of survivorship, is there any evidence that too much exercise is more or less beneficial?
So not that I'm aware of. But the thing is, not too many people are prone to overexercise. So the data are pretty sloppy. But in non-cancer data, the hardcore endurance athletes do seem to have a lot more heart disease. In terms of arrhythmias, it's probably significant. In terms of other forms of heart disease, it may not be. But we've never seen patients who are inclined to overexercise too often. And those that do, like the 100-milers and stuff, they don't want to listen to me anyway, so they just get their AFib and they're happy. Did I answer your question? Yes. Yeah.
Would you mind giving 2, 3, 4 examples of other forms of quick exercise, like the skip roping, that we can do for a minute or 2 or 3 several times a day?
Jumping jacks,
Convenient.
high steps. Do this for a minute.
Wall push-ups,
Wall push-ups or real push-ups.
counter push-ups.
Wall push-ups. Sit to stands, yeah. I mean, getting out of a chair 6 times for some people is a challenge all by itself. Squats, burpees. Now you're talking. You can tell this guy's hardcore. Ping pong, this is part of my longevity lecture as well. Ping pong actually is the exercise most strongly related to reduction in dementia risk, in case you're wondering. The Japanese really have done a lot of research in this. And
You always involve another person.
yes, yeah, because exercise that's social, exertional, and requires strategy and hand-eye coordination appears to actually be really good for the brain.
Especially when you can talk and laugh while you're playing.
Yeah, people laugh at me when I play ping pong quite a bit.
Let's hear it for pickleball.
Yes, well, the thing is, in this age group, Maureen, there's a lot of ACLs and torn Achilles and stuff, so some people are sensitive about that. Yeah.
Actually, this age group is the one that plays pickleball.
Right, and Phil, as my orthopedic patients say, it keeps their offices busy. Yeah.
The miles about alcohol. Do we have to distill our own at home, or is it okay to buy it?
I'm pretty sure it's okay to buy it.
And is whiskey okay?
The best study I know, there's something called the Morgan study, Morgann. published just a couple of years ago that really, big study, lots of people, and I apologize, I can't cite the actual data, and really split it down in between types of alcohol and cancer and disease outcomes, including cancer. And it seemed to show, as so many other studies have shown, that there's a trend towards superiority for red wine, especially with respect to cancer, but that for most health outcomes, whiskey worked. But there does seem to be a benefit for red wine over other forms, including over white wine. And it's plausible, I think, the phenolics and so on in red wine, there's a biological plausibility to that argument. But it's all pretty fuzzy data because, A, do people tell the truth about what they're drinking and how much they're drinking? There's all kinds of problems with the data.
I hate to get away from the alcohol discussion, but comments about the forever chemicals and association with cancer, and whether we should all be drinking filtered water or bottled water instead of our tap water. I think it's probably early science, but
so I've been sort of in the lifestyle medicine, natural food realm since I was a teenager. And so I'm kind of cynical because every year or every couple of years there's been some new group of threats. And then after a few years, those threats are gone. So in the absence of really strong data, I figure people have enough to do with what we actually know about to not worry about microplastics. And plus, if you're eating whole foods cooked at home, you're automatically getting rid of a lot of these contaminants anyway. So I find it hard to get excited about those forever chemicals. And the other thing is, they're here. And if you look at up until about the late 2000, the 2015, 2020 region, the lines may be deflecting more recently, but we've had this long stretch of increased longevity, increased quality of life at later ages. And so, you hear people saying that 70 is the new 60. Though I did have a patient say, 60 is the new 50 and 70 is the new 60 and 80 is still 80. He said that yesterday. So anyway, but he was a lawyer, so he's really cynical. But it's hard for me to not see this trajectory of what appears to be improved human condition at later ages and get really excited about our environmental chemicals. It seems like if they've been such a problem since World War II, we'd be seeing more harm. Now that may turn around with something. And in actual fact, the longevity curves in America seem to have started deflecting down in, not lowering, but the gradual improvement we've been seeing since World War II seems to be flattening or even going down since about 2015 or thereabouts. So time may show that I'm wrong, and of course some people like me are just inclined to blame all that on obesity anyway, so because obesity is such a, what's amazing is even as Americans are getting fatter, they've been living longer. Okay, so Shelley has some questions I'm supposed to answer. We've already answered the cocktail one. The one that somebody asked me to refer to is organic versus non-organic foods. I don't know if, we just can't find anything in that discussion to base it on. So we say, eat whole foods that you made yourself. If you want to buy organic, that's fine too, but I'm not aware of any basis on which to say that you should have organic over non-organic. Does anybody have any basis otherwise? Am I missing something? I feel like it's just an assumption out there, and I just, especially when you're talking to a single working mother of 5, and she's running around trying to find organic broccoli. Feed your kids broccoli, I don't care if they're organic or not. And so I think, and we have 30 or 40 years of data on this, and just nothing has shown up so far. We dealt with alcohol.
Yeah, but not cocktail, a huge difference.
Oh, Mia wants me to address the fact that when we're talking about alcohol, we're not talking about cocktails. Because cocktails are like 300, 400, 500, 600 calories each. Tons of sugar, there's basically soda pop with some alcohol in them, so there.